Good afternoon. Can everyone hear? Okay. So just before we get into this is going to largely be a discussion about just ECMO. What's your experience with ECMO? Some contact, a lot of experience, a little bit, just kind of, who's at least seen a device? Perfect. Okay, that's good. Okay. So first off, no disclosures related to this particular presentation. I thought what I'd do is just start off with one of the cases that we've encountered in the last 6 months. And then we'll go through just some of the specifics for ECMO, so just what the equipment is, what some of the outcomes are. And then we'll look at it a little bit more with regard just to how it's been applied in COVID and what some of the literature is, just so you have some background with that. And I'll try to time this for about 45, 50 minutes or so, but please just stop if anything doesn't make sense. I'm happy to answer some questions. So first off, this is one of our patients. So it's a 58-year-old woman. You can see the demographics there. She's not without comorbidities. She's about 110 kilograms. And she was admitted to our institution with acute respiratory failure, which had been present for about 4 days prior to her transfer. About 2 weeks earlier, she developed upper respiratory tract symptoms. She received an antibiotic. She took it, not surprisingly, didn't get better. She had a nasal swab performed at the time that did return back positive for COVID-19. She was treated with remdesivir and dexamethasone, and just by history, had not been vaccinated against COVID-19. This was actually at a time when vaccines were not quite yet available. So at an outside emergency room, she was in profound distress. She was intubated, placed on mechanical ventilation, ultimately transferred. Hypoxemia worsened despite a broad array of treatments that included antibiotics, diuretics, inhaled nitric, as well as paralysis, a lot of the interventions that we do for severe ARDS these days. You can see her P to F or PaO2 to FiO2 ratio is 86, which is in the severely impaired range. You can see the rest of her blood gas. She's hypercapnic with a PCO2 of 58, pH of 726. She was on vasopressor. She was treated with broad spectrum antibiotics because it was flu season. She also got oseltamivir. And not surprisingly, she started to experience extrapulmonary organ dysfunction. In her case, it was oliguria and impending AKI, renal insufficiency. You can see her initial chest x-ray here, characterized by bilateral pulmonary opacities. Can everybody see? Okay. Worsened pretty quickly. You can see the endotracheal tube present now on the right image to you. This is her CT scan. It's characterized by bilateral opacity, some ground glass changes. You can see some prominent air bronchograms present as well. And so diagnostically, she meets all of the criteria for ARDS, and we'll get into her transition to ECMO shortly. I know you had an ARDS lecture this morning, so I'm not going to belabor a lot of this. Just keep in mind that it's very common. 20% of ICU patients meet criteria. The annual incidence is common. And importantly, the incidence is relatively unchanged over time. If you think about our interventions, managements, our medical therapy, we really don't have much more than comes down to how we manage the ventilator and what we do within the first 24 to 48 hours to manage these patients. So the mortality is pretty substantial, and even patients who survive still have an ongoing high burden of illness that persists for months after their acute illness. So we all know that the Berlin definition is how we currently define ARDS. It's interesting that several respiratory societies ultimately got together and endorsed this particular definition. I think what's nice is, at least as you apply it to research subjects, it really delineates mild, moderate, and severe disease. And again, you may have seen this morning, but again, we look at the timing of onset of ARDS, the chest imaging, typically bilateral pulmonary opacities, The origin of the pulmonary edema, remember it's non-cardiogenic, absence of increased filling pressures or hydrostatic pressures. And then the degree of hypoxemia, as you can see in the table below, signifies the severity of disease, with those folks that have PaO2 to FiO2 ratios below 100 being categorized as the most severe in the ARDS category. So you can see our case patient already met the definition of severe ARDS. Again, pathophysiology, I won't get into it too much here, just suffice it to say that it's a very cytokine and neutrophil predominant reaction in the lung that characterizes the gas exchange impairment that's there. You lose a lot of membrane integrity, causing gas exchange impairment with hypoxemia and hypercapnia. And again, if you look at just the natural cause, it kind of, very simply placed, comes down to the insult that causes it, whether it's intrapulmonary or extrapulmonary. There are a lot of host-dependent factors like genetic predisposition, the occurrence of chronic illness in the person, other external or environmental factors that might influence the disease course. And then there are risk attenuating factors like appropriateness of care, how we manage blood sugars and other ICU-related interventions. And really, these are the things, as well as others, that largely come down to whether somebody is going to recover from an episode of ARDS or progress to multiple organ dysfunction. You all know this, mechanisms of injury, and this is why we start to think about ECMO support, particularly in these cases. So we've all heard of barotrauma, the high pressure in the lungs from the ventilator that typically leads to problems like pneumothorax, pneumomediastinum, sometimes even air around the or within the pericardium. There's also volutrauma. So, the lungs are kind of heterogeneously affected with ARDS, and areas that are relatively preserved or normal are subjected to over-distension because the areas that are evolved are very stiff and less compliant. So you get this difference in how different parts of the lungs inflate with mechanical ventilation. There's also atelectotrauma, so the collapse and the re-expansion of lungs thought to contribute to injury. And finally, perhaps we don't, I guess we keep this in mind, but hyperoxia. So you just heard the beneficial effects of hyperbaric oxygen, but there are potentially some harmful effects of prolonged oxygen exposure with hyperoxia, leading to free radicals and potential injury to the lung. And so our goals are always to try to get the FiO2 as low as possible, using PEEP where needed, and then potentially considering alternatives like ECMO support. So again, we talked about the strategies used to improve outcomes with ARDS. Remember, this was the landmark study comparing 6 versus 12 cc's for tidal volume, showing that there was a mortality benefit for patients that were ventilated at lower tidal volumes. But there are consequences to lower tidal volumes. So what happens to carbon dioxide levels? In patients with severe ARDS, they typically rise, pH drops. Are there harmful effects to cellular metabolism because of those kinds of consequences? Some would argue possibly. And so because of this, we have to be mindful of trying to regulate acid-base balance in these patients as well. And so when we start to think about how to approach patients with severe gas exchange impairment, there are a number of strategies, and there's several here that are on the board. Typically, we're using low tidal volume ventilation for all patients that have lung injury. We're adjusting PEEP and increasing settings in PEEP where needed to try to improve gas exchange and, importantly, to lower FiO2. For early severe ARDS patients, we're using paralysis. We're often using prone positioning for those patients based on 2 studies that have suggested improvement. But I want to focus a little bit more now on kind of the extreme of that spectrum, where we talk about ECMO and then this concept called ECOR. So ECOR just stands for extracorporeal carbon dioxide removal. And I've got some slides at the end of this just to show you what that implies. So let's talk about ECMO first off, okay? So, most of you are probably aware that ECMO has been increasing, both in terms of the numbers of patients supported as well as the number of centers performing ECMO. And you can really see since about 1999, 2000, there's been tremendous growth in both of those. There are a couple of events that happened around that time. First off, publication of the Caesar trial, and I'll tell you about it in a slide or two. The other was that, if you remember back, there was an H1N1 influenza pandemic around that time. And the use of ECMO supporting those patients and demonstrating that it was both feasible and led to satisfactory outcomes got around. And that really kind of fostered the interest in applying ECMO to patient groups with severe ARDS. Okay? So there have also been changes in technology. So the cannulation strategy, the pumps, the anticoagulation, everything really has gotten better in the past 10 years. There's a lot more provider experience that has come about. I'll tell you about some of the clinical trials in just a second. And then I think importantly, we're selecting patients better. And like anything, if you start off with a patient that's moribund and has a low likelihood of survival, under those circumstances, ECMO unfortunately is not likely to help improve the outcome. So I heard the previous speaker talking about randomized trials. And if you think about the number of randomized trials that we've had for mechanical ventilation in the ICU, weaning in the ICU, sepsis, antibiotics, you name it, most interventions are fairly well supported with a fair amount of randomized trial evidence. At the moment, there are 2 in ECMO, which, given the technology and given the growth, there really hasn't been that much. These are the 2 studies. So the first was the Caesar trial. So it randomized just 180 patients with severe ARDS to ECMO, and I'll tell you what ECMO was at this particular center, versus conventional management, okay? And because this was really performed, it was performed at several centers in England, but England only had 1 center that was performing ECMO at the time. So the strategy was you either got randomized to the center that performed ECMO or you stayed where you were. Now remember, this was before low tidal volume ventilation. This was before a lot of standardization in critical care. So if you were randomized to ECMO, you went to the ECMO center. That does not mean you actually got ECMO. And in fact, only about 2/3 of patients in this trial got ECMO support. But they concluded that if you were randomized to this particular strategy, you had a statistically improved outcome and chance of survival. The other trial that was done was almost 9 or 10 years later. This was a New England Journal trial. It's called the Wille trial, and it's largely a European trial. Randomized actually 240 patients with severe ARDS. So the PF ratio, just like our case patient, was less than 100, randomized either to early ECMO support or to conventional mechanical ventilation. Now they had the option to cross over to ECMO if in the provider's judgment, the patient had a high risk of dying on conventional mechanical ventilation, but they analyzed it according to the intention of the group that you were assigned to. So they actually found no mortality difference. I guess you could argue with a p-value of 0.07, there might have been a trend toward a favorable effect of ECMO, but statistically, not a difference between the 2 groups. They actually stopped this trial prematurely because of predefined futility criteria. And importantly, a fairly large number of patients crossed over from the ventilator group to the ECMO group, perhaps muddying some of the outcomes. However, both of these studies suggested that VV ECMO, veno-venous, is a reasonable option for severe ARDS where conventional mechanical ventilation strategies have failed. Okay, so what do we use ECMO for? Where do we consider it? So, The two classic and probably more common indications are hypoxemic respiratory failure, with ARDS being the classic example, hypercapnic respiratory failure, status asthmaticus, severe COPD exacerbations. But you can apply it in other areas as well. So complex airway disease, so a resectable tumor that is obstructing the airway, where an alternative source for gas exchange might be required. We've used it a few times in traumatic cases, individuals who, for example, have been shot, had to have a pneumonectomy, and just allowed time for the opposite lung to recover. Pulmonary hypertension, and then transplant-related. You can use it to sometimes bridge patients to transplant procedures. And I guess whenever we're thinking about starting a patient on ECMO support, we're really looking at what is the goal of the device. Are we trying to bridge someone to recovery, to come off of device and ideally off of oxygen? Are we bridging them to transplantation or to durable device therapy? The durable devices are a little bit more well established in cardiology compared to respiratory. Cardiologists have VADs, for example, that can be used on the outpatient basis. And the last, bridge to moratorium, is, not too sure if this person has capacity to recover, not sure they're a transplant candidate, but it's reasonable to give them a chance and see what happens. We don't like to do that very often because a lot of times patients get trapped on an ECMO circuit and don't really have a good way off, but it is a strategy. And importantly, having a strategy for coming off of ECMO is important as well. So what does this help us accomplish? So by going on to ECMO and ideally extubating the patient, we can avoid the complications of mechanical ventilation. We can provide time for recovery of the lung from the acute injury. Ideally, we can limit the multiple organ dysfunction that sometimes results from lung injury. We can lighten sedation. Often these patients need little to no sedation. They can be awake. They can breathe through their mouth and use their lungs. They can communicate. Importantly, early mobilization is an important part of this. You can see in the picture, this is one of our patients walking with physical therapy. And again, the goal is just to minimize the risk associated with the ventilator. When we think about contraindications, there are a few. Probably the biggest ones revolve around the presence of multiple organ dysfunction, because just like what happens in the ICU, if you have a ECMO patient with multiple organ dysfunction, odds are the outcomes are going to be less successful. We used to say contraindication to anticoagulation, and there are some instances where anticoagulation is needed. I think we and other centers are finding that you can get by with less and sometimes no anticoagulation in these patients, so we don't really consider that an absolute contraindication anymore. I think importantly, if you have an irreversible disease process, that's probably a reason not to start ECMO support. The other one in this group that sometimes is debated is the duration of mechanical ventilatory support prior to ECMO. Most of the clinical trials have used a 7-day window, and that's usually what we've stuck with, as well as other programs as well. So it's just important to keep in mind. The concept, or I guess the theory, being that the longer the delay from mechanical ventilation to ECMO, the greater the likelihood that this inflammatory phase of ARDS converts to a more fibrotic phase, and the less likelihood for lung recovery. So that's our interest in trying to make an early transition. So I'll try to do this quickly just in case there's anyone who hasn't seen this. So just the basic concept of ECMO. So you need cannulas, you need a pump, and you need an oxygenator or a mechanism for gas exchange. And then there are some other elements that you can put on as well. So this is a typical veno-venous cannulation. You can see in the blue dot, the blood is coming out of the femoral vein. It's running through the pump, which drives blood flow, through the oxygenator for gas exchange. And in this instance, it's returning to the same IVC through a separate femoral vein, okay? So importantly, veno-venous ECMO supports the lung, really doesn't support heart function or hemodynamics. Okay? We're not going to talk so much in the remaining lecture about veno-arterial ECMO, but I put this up just to show you the difference. Okay, so you can see one cannula is draining from the femoral vein, again goes through the pump and the oxygenator. We'll talk about these components in just a second. In this case, it's returning to the femoral artery. Okay, so the heart and the lungs are seeing part of the cardiac output here. It does support gas exchange and lung function, but you also get support of heart function, and that's one of the main differences between veno-venous and veno-arterial, is that you do get cardiac or hemodynamic support. We'll talk about circuit components. So first off, the pump. You can see most of these pumps are all shaped the same way now. So they're largely centrifugal pumps. So they're basically magnetized, or they have a magnet in a motor that spins the pump head very quick. So, 2 to 4,000 revolutions per minute. It's the centrifugal forces that propel the blood through the circuit. And you can kind of think of at least these pumps as having a vortex effect, or it's almost like a tornado. So it pulls blood down through a low pressure system in the central part, and then where the pressure's higher, it kind of ejects at the periphery. So these pumps are preload dependent, meaning you need volume for the pump to work. They're also what's called afterload sensitive, in that you can shut off the pump if the circuitry kinks or gets clamped, or something happens to the cannula, thrombosis, so you have to be a little careful about the pumps. The oxygenators these days are largely polymethyl pentene based, but essentially just hollow fiber membranes. You can see in the illustration. So it's almost like a dialysis membrane, where you have a semi-permeable membrane, except here it's gas or air or oxygen and blood flow that are separated, and gas exchange occurs in that mechanism. And then finally, you need a way to get blood out of the body and return it to the body, and that's where cannulas come in. So there are lots of strategies to cannulate patients. You can see in the bottom picture, that's the femoral approach. In the, you're right, picture, it's central. We don't have to rely on that too much. That's actually, obviously surgically inserted. And there are several configurations that can be done. The picture on the left represents what are called dual lumen cannulas, which have increased in frequency and use recently. So these are just two. I think there are 3 on the market right now. But essentially, they can be placed in the internal jugular, usually, and allow for a single site where blood can be drawn from and returned to the body. It frees up the legs to allow for mobility and ambulation, cuts down on the number of sites that are necessary for cannulas. So what are some of the complications that we deal with? So you can think about these related to the patient, related to the catheter itself, and related to the device. So again, part of the issue with anticoagulation relates to bleeding. Have you guys seen these cannulas? So I think if you look at your, 3rd, 4th, or 5th finger, that's about the caliber of some of the cannulas that we use. So pretty sizable. So not surprisingly, when placed, it can lead to some bleeding and hemorrhage. Patients can also get hit if we use heparin a lot. In terms of the catheter, particularly the cannulas that are in the internal jugular, they're sometimes susceptible to positioning and can become malpositioned if they either rotate or if they advance or retract. Cannulas can clot off sometimes, and then the device can sometimes develop clots. Often it just loses efficiency as time passes. And then obviously air embolism and venous embolism can be problems as well. So not COVID specific, but if you look at just the outcomes for ECMO support, okay, again, remember these are pretty severely ill, respiratory impaired, or cardiac impaired patients. And I just boxed the adult patients. You can see the neonatal and the pediatric outcomes are a little bit better. So adult patients surviving to discharge for respiratory failure, it's about 60%. For cardiac failure, it's about 40-45%. For patients that can go on to ECMO after or during CPR, it's closer to about 25-30%. Okay? We'll get to the COVID-specific numbers shortly, but they're a little bit lower than these numbers. So I tell folks usually about 60-45-30 for respiratory, cardiac, CPR. Okay. So we'll switch over and talk. How are we doing on time? Okay, good. So we'll talk a little bit about just ECMO as it applies to COVID. And, I think I'll show you some of the outcomes in just a second, but it was pretty clear to everyone who does this that it was really not clear how ECMO was going to fare in the COVID area, largely because of a lot of the complications that come with COVID. There's increased bleeding, there's increased clotting, there's more of a multi-system inflammatory problem, irrespective of ECMO, and different than our experience with influenza and most other causes of ARDS. So, and even the CDC at the time had said that really there's nothing special about this at the moment because nothing was known. And so just to treat COVID patients as you would any other patient with severe ARDS. Acknowledging there's little worldwide experience in using ECMO for these patients. And I think, as you might imagine, the initial literature that emerged was not so favorable with regard to ECMO. This was one study that came out of the French group, one of the earlier studies published, their experience with 17 patients. And you can see that there were, I think it's about 6 or 7 that died in this cohort. Several were still hospitalized. If you can see the asterisks from where you were sitting, those are the patients that were actually discharged from the hospital. And these were patients with severe ARDS, PaO2 to FiO2 ratios less than 80, so definitely meeting the severe ARDS criteria. What they also commented on were the complications. And again, I think this is where COVID has been different than much of the other support that we've provided. So they saw AKI requiring renal replacement therapy in nearly 70% of their patients. Ventilator-associated pneumonia, almost 60%. And remember, I said it's good to try to get patients off the ventilator. So the fact that patients either had to have tracheostomies or continued ventilator support is not the strategy we like to use. Fair amount of bleeding, DVTs, pulmonary emboli, and then clotting of the oxygenator. So a lot of adverse events. So the ELSO group, which is the Extracorporeal Life Support Organization, published data next, looking at registry data. And they had about a little over 1,000 patients representing 200 hospitals, 36 countries. Now you might imagine practice variation is fairly wide in such a large group. The pre-ECMO patients were fairly sick, but also fairly young. These patients were about 49 years of age on average. And you can see that there was an increasing trend toward mortality and actually a significant increase in not surviving ECMO COVID as you got older in age, with patients above 70 years of age having the greatest problem. And it started to separate really at the age of 50 to 59. You could see an increased trend. But it gets worse as patients got older. Surprisingly, perhaps not surprisingly, no difference among ethnic or racial groups. So that didn't seem to impact anything. So thinking about genetic factors predetermining outcome didn't matter. If you were immunocompromised, you had increased risk of not surviving. If you had chronic respiratory impairment of any kind, asthma, COPD, pulmonary fibrosis, you were less likely to do well on ECMO support. And then finally, if you developed or started ECMO with acute kidney injury, you were less likely to survive. The one I didn't highlight was if you started under cardiac arrest circumstances, because that seems obvious. And again, this group showed that the in-hospital mortality was about just under 40% at 90 days, with about 57% being discharged alive, okay? And if you look, by comparison, the Eolia trial that we talked about before, it was about a 35% mortality at 60 days. So a little bit worse, but not drastically. There's been some more recent data, and again, this is somewhat retrospective data entered from multiple centers. And again, these are largely US centers looking at the outcomes, comparing COVID patients supported with ECMO versus COVID patients supported with conventional mechanical ventilation. So the ECMO group's in red, the ventilatory patients are in, I guess, green or black. Okay. And you can see that in this particular cohort, and again, it was about 190 patients, the patients who received ECMO support seemed to do better compared to conventional mechanical ventilation. 33% dying compared to 47% dying in this particular group. Now, they also recognized a high occurrence of complications. So again, pneumonias, bleeding, thromboses, and so forth in this particular group. But this is largely US-centered data suggesting that ECMO might offer some benefits. Now, you could make the case with that kind of study that not all centers adopted the same criteria by which patients went on to ECMO support. So it might not be a fair comparison. So a lot of these studies, and this one too, was asked to do what's called a sensitivity analysis, and essentially just modify the definition of the case patients a little bit, and then make comparisons again. And so if you look at sensitivity analysis 2, sensitivity analysis 3, what they're basically doing is just trying to better match patients according to comorbidities. And I thought what was really interesting here is if you look, I put a circle around it. So no matter how you defined and compared the patients, and even just trying to match patients as well as possible, the evidence still seemed to come down in favor of ECMO as supporting a favorable outcome. And again, just going on, looking at how long you can support a patient with mechanical ventilation prior to considering ECMO. The shorter duration is better. So graphic to your far left looked at 7 days greater or less. The one in the middle looked at 11 days greater and less. And there's still some benefit at 11 days, but it's perhaps a little less than 7 days. The one on the right looked at age. And again, and the cutoff there was 70 years of age. So if you were less than 70, you fared better compared to patients who were over 70 years of age. Okay? And just in terms of a general time course, most patients had kind of gone from intubation to ECMO support an average of about 4 days, okay? With about 14 days of symptoms beforehand and a hospital duration, and ours are comparable to this, of about 45 days, okay? So early ECMO and then effective ECMO, patients that can be extubated and walked or participate in physical therapy seem to have the best chance of survival from COVID. And I think So I think one lesson that we've learned is that COVID is not influenza. We can't apply and expect the same kinds of outcomes in COVID that we've had with influenza. And the question becomes, is it because of just the marked pro-inflammatory state that sometimes comes and that we've all seen with these patients or not? And so in this graphic, so you can see I put a couple of arrows as to when is the optimal time to try to intervene with ECMO, and does early ECMO offer any advantage to lessening the inflammatory state that often accompanies these patients. The one thing that we have appreciated, and perhaps this was discussed this morning, is that phenotypically these patients may be different. Again, we characterize all patients as having severe ARDS, but the fact is they may not be the same and may not respond to the same interventions or therapies. So one of the earlier observations, if you remember back with COVID-related ARDS, was that the compliance for these patients was not as severely impaired. They could still take deep breaths, didn't require a lot of pressure on the ventilator. They were profoundly hypoxemic without the decrement in compliance. So arguing that these patients may respond differently compared to some of our other patients. I'll show you just some of the current numbers. I pulled this, I think, yesterday from the ELSO registry. So in-hospital mortality, and these are patients who've been supported for at least, so back 3 months. So they've got at least 90 days of follow-up data. So current in-hospital mortality is about 49%, and you can see it's about 6,500 cases worldwide that have been supported with ECMO, obviously a lot more infected. You can see a majority of these cases are in North America with spattering throughout the rest of the world. So the ECMO run, so 339 hours is about 2 weeks of ECMO support, and that's median value. We've had patients that have required several months of support to try to improve. Some of the more common complications, stroke, hemorrhagic as well as ischemic, intracranial hemorrhage, renal failure incidence is just under 30% right now. And then patients off ECMO are still in the hospital, at least in this cohort, about 8%. And remember, those are patients that have had at least 90 days beforehand. So about 8% of patients are spending months and months in the hospital. And this is just the ECMO population. And we talked a little bit about the outcomes. This just shows the graphic. In-hospital mortality, about 49%. Remember the factors associated with an increased risk of mortality: advancing age, immunocompromise, cardiac arrest, presence of AKI. And then if you start on VA support as opposed to VV support, the concept being that if you're in shock at the start of this, you're less likely to do well. So I'll show you some of our data. This is just our average daily census for COVID versus non-COVID patients. The green bars represent the COVID patients, and at the peak, which was around February, we averaged about 10 patients with COVID on ECMO per day. It's dropped off a little bit. It's picking back up last couple of weeks. These are some of the demographics. So you can see the median age is just around 50 years of age. There we are. So more males than females. BMI of about 32. Let's see what else. I'm sorry, I should have said, so our data is the green bar. The yellow bar represents ELSO, or just national data, if you will, or worldwide data, really. So it's just a benchmark comparison. And then finally, if you look at outcomes, so we've had about 60 patients as of June thus far since this started. The median duration, sorry, it changed the value for some reason, but so it's been about 35 days of support. Length of stay has been closer to about 45 to 50 days. About 50% of patients have been able to wean off of ECMO, and about 48% of patients have been able to survive to discharge. So, and I'll add that these numbers are substantially lower than what we see for influenza, for most other non-COVID indications of severe ARDS. I should mention that lung transplantation, because we sometimes bridge patients, we've actually had one patient with COVID thus far, in Alabama who bridged to successful lung transplantation. It's probably going to be something that's happening more and more just as patients are left with fibrosis, respiratory impairment, but hopefully it's the minority of these patients. So I wanted to just change in the remaining minutes and talk a little bit more about hypercapnia and the role for extracorporeal CO2 removal. Okay, we've been focusing more on the hypoxemia end of this curve, but keep in mind that the other indication for extracorporeal technology is largely hypercapnia. So what is ECOR to start with? So it's an alternative to full flow ECMO support. So you can think of it as hyperventilating an efficient oxygenator. You all know that carbon dioxide is very efficiently cleared, okay? And so this makes use of the concept that because carbon dioxide is very easy to remove, you don't need as much blood flow in a circuit. You can get by with less blood flow. And if you can get by with less blood flow, you don't need large ECMO cannulas to accomplish this, okay? So you can get by with smaller, safer cannulas. You really don't need a specified ECMO center. You can do this in an ICU setting. There can be a pumpless configuration, as is shown in this figure. There used to be a device called the Novalung, which we used early in its inception to bridge 1 or 2 patients to transplantation. And essentially it was just a pumpless device, so it relied on intrinsic blood pressure to push blood from an artery to a vein through the little white membrane oxygenator that's there, and it would just pull off largely carbon dioxide. So just quickly, the characteristics. For ECOR, you don't need high flow rates. So again, don't need high flow rates, don't need the fancy pumps and devices and so forth. You don't get much oxygenation, but you get adequate decarboxylation or CO2 clearance. And again, these can be performed in an ICU setting. So where might it be considered? So you can consider it for moderate or severe ARDS when the goal is typically to try to reduce your tidal volume. You may not get much of a benefit for oxygenation, but it can help to reduce tidal volumes, largely by attenuating the drop in pH or rise in carbon dioxide. You can use it for COPD. In fact, there have been some clinical trials looking at prevention of intubation or facilitating earlier extubation in patients who have COPD exacerbations, and then status asthmaticus as well. And this is just one of several trials that have been published looking at, so what you see on the left graphic is a drop in driving pressure corresponding with a drop in carbon dioxide removal without a subsequent increase in respiratory rate in these patients. So they don't have to breathe as deeply and they don't have to breathe as quickly with the use of this kind of device. To my knowledge, there's not outcomes data just yet, but there is actually an FDA-approved device now which accomplishes this. And we talked about these. Okay. So what are some of the future directions in ECMO? So there's a lot to continue to be learned about the application of anticoagulation, and specifically, how long can we get away without anticoagulation? Thresholds for monitoring and replacement of blood products. Nobody likes to give or receive blood transfusions, but it happens frequently in ECMO support. I think infection risks are pretty common, so trying to reduce infections. Models to predict who the best candidates are to support are important. The area of pharmacokinetics in ECMO is almost untapped. Optimizing rehabilitation in these patients, being able to get them up, sitting to a chair, walking, ambulating is important. And then obviously we hit safety and portability issues, as well as a number of ethical issues for these patients. So just quickly in summary, there are select patients with acute respiratory failure who may benefit from extracorporeal support. If these patients can be identified earlier and referred, they're more likely to benefit from extracorporeal support. There are lots of questions remaining with regard to how to manage these patients ideally. and it's an area of ongoing research. Don't forget about eCore. As I mentioned, there is at least one FDA-approved device now, and I have, I have no conflicts with that device. But it's an effective way to treat patients with hypercapnic respiratory failure. And finally, don't forget about SARS, COVID. ECMO may have a role for a number of these patients. But again, the earlier the intervention can be, the better. And with that, I'll stop and just take any questions if anybody has one.